Nothing.
Hello. Hey, what's up? Oh no, I'm well at it. I'm just gonna do. John and I are just doing rounds here this morning. In about one minute. Yeah, nothing. Well, it wouldn't.
per CH.
Healthy Rockets Fallout in Eagle Ridge. Can you just ask them, sound was initially earlier, but can you just make sure the microphone on the podium is on? Okay. No, but I did initially, and you guys heard us, and there was a two-way street, but it's lost now.
Hi, Eagle Ridge. It looks like your mic is
Yeah, we
unmuted.
got it. Okay, thanks. Bye.
Hi, the number.
Hello?
Hi, it's RCH here. It looks like your mic is unmuted.
Hi. Just...
I thought that Brenda was going to come by and do an introduction.
Oh, I thought it was 7:30.
Yeah, we should.
Mic's on, and whenever during question and answer, just turn this one on.
Okay, we should. Get a little more volume for the mic. Hello? Okay, we should probably get underway. I thought that Brenda might be by to do an introduction, but it's 7:34, so we gotta get through rounds because we all gotta get to work. So I'm Paul Sobey, my associate John Cohen with the RCH Addiction Service. Brenda asked us to present today on safe opiate prescribing and really to have a talk around, have a discussion around providing care for opiate addicted or high risk patients that come into hospital. And increasingly, of course, we're seeing a lot of these patients. And so John and I are going to present on this. I'll talk first of all. John's going to talk and then interrupt at any time and for any questions. And at the end, we'll have questions. We've only got about 30 slides, so we can get through the slides fairly quickly. So what we're going to talk about is we're going to talk about safe prescribing practices for the opiate addicted or high risk patient within an acute care setting, what our consult service can offer you, and planning for discharge and safe prescribing practices for opiate addicted or high risk patients, including what do you do when you see these patients in the community, some advice for that. So this is what it's all about, is that we have this item called the opiate prescribing epidemic that you may have heard about in the news. Just briefly, we're in the 6th noted opiate prescribing or opiate epidemic. The first 5 historically occurred after conflict and war. So individuals would go to war. First time there was an opiate epidemic was the American Civil War, when morphine was largely used for treating battlefield injuries. The individuals that would get addicted would be lower socioeconomic background, i.e. Those are the people that went to the front lines. People from higher socioeconomic background went to officer school. The epidemic would self-extinguish when they came home for a variety of reasons. But in the 1980s, there was a continuation of the opiate epidemic that really came out of the Vietnam conflict with prescription opiates and also other reasons. It's not just simply prescribing of opiates and the Purdue phenomenon. There was other reasons too. There was transportation, worldwide consolidation of drug cartels, etc. Very, very interesting phenomena. And then pharmaceutical companies come up with very sophisticated marketing models. The physician expert model was the one that was predominantly used. And now what we're seeing is a medium to high socioeconomic background, younger, prescription-initiated individuals that are addicted to opiates. Increasing fatal, non-fatal overdoses. And initially it was all prescription opiates, but now we're into this secondary phenomenon of new psychoactive substances, notably fentanyl. So as everybody knows in the room, heroin is diacetylmorphine. You got a couple of acetyl groups stuck onto a morphine molecule. The morphine molecule can't take another group on it. It just doesn't work. So you can't really alter the potency of it. Fentanyl is a different molecule. You can hook on a whole bunch of different moieties to it. It's similar to the amphetamine molecule. It's very manipulatable, and it alters potency dramatically. So if you take pharmaceutical fentanyl as compared to carfentanil, which is a veterinarian form of fentanyl, there's 1,000 to 2,000 times potency difference. And we see this now in that the manufacturers of synthetic forms of fentanyl are making these altered forms of fentanyl, and it's resulting in clusters of opiate overdoses. So really interesting phenomenon. So there's a secondary opiate epidemic coming around in the form of synthetic forms of opiates, the new psychoactive substances. I talked about this, I think, about a year ago. There's amphetamines, tryptamines, piperazines, and opiates as individuals manipulate old molecules. As a friend of mine from the 1960s said, there's really no new music. People just alter old music. Well, there's no new drugs. People are just playing around with old molecules. Well, yeah, and here's the issue. Who knows? Because we don't have the sophisticated means of determining what's what. We test for fentanyl, norfentanyl, which are norfentanyl is a metabolite of pharmaceutically produced fentanyl. We're not testing for allofentanyl. We're not testing for other key metabolites of the synthetically produced fentanyls. So a lot of this information we just don't know. This is the key issue here. This is United States data. We don't have good data for Canada, but you can see the red outline. This is the number of fatal opiate overdoses in 2014 in the United States, 18,000, call it 20,000. So we would assume that we had 2,000 in Canada. I would put it out that we have had more because we take more opiates than the United States does, and especially in our locale here in the Lower Mainland, we consume massive amounts of opiates. And they talk about the heroin epidemic a lot in the United States. And, heroin is a term that, from my perspective, I think that the U.S. tends to use, and the U.S. media tends to use, because heroin is from outside. And there is a gestalt to the American psyche that from outside is bad, and we can deal with that. But when you talk about fentanyl, it's from inside. And really, when you talk about heroin overdose deaths, how many of those deaths are actually also fentanyl and a metabolite or a synthetic form of fentanyl that wasn't detectable? So some of this data may be a bit skewed, but what you need to know is that a lot of people are experiencing fatal overdoses with opiates, and a lot more are experiencing non-fatal overdoses. Article in the Globe and Mail from last weekend, really interesting article about how Canada got addicted to fentanyl, and talks about some of these kind of issues that I've just talked about. So, 1964, Canada was taking about 2 milligrams oral morphine equivalents per person per year. And as you can see, Australia might have been taking 8, the US might have been taking 2 or maybe 3, and the rest of the Western world countries were taking very small amounts of opiates in 1964. 2 milligrams oral morphine equivalents. This is at a time when there was an opiate prescribing phobia around. We needed to be careful with these drugs. People could get addicted to them. I think a lot of physicians in 1964 were had the experience of the Second World War or other conflicts, and were aware of what could occur with opiates. 2013, we're taking 98 milligrams oral morphine equivalents per year. And I got to ask you, is there that much more pain? And so it's gone up 50-fold in Canada. Now, Ontario takes the most amount of prescription opiates, but it's a little different out here in British Columbia. There's substantially more synthetic fentanyl and other synthetic opiates out this way. Are all the other sites, do you have your microphone on mute, please? Eagle Ridge and Burnaby. Yeah, so if you, please put your phone on mute. So prescription opioid use has gone up about 50-fold in the last number of years. And I ask you, is there that much more pain? And there's a variety of reasons for this. It's pharmaceutical modeling, it's transportation, there's a whole bunch of different reasons. But regardless, here's where we're at right now, is we take a huge amount of opiates, and the huge amount of opiates has resulted in an addiction epidemic, and non-fatal and fatal overdoses, etc. Key issue here is that oral morphine equivalents and fatal overdose and also non-fatal overdose are geometrically related to dose of opiates. So that key number, 50 milligrams oral morphine equivalents, is a really key number in preventing overdose and other consequences to opiate use. Once you go over that number, and that's a number that we as practitioners, I think, really need to know, once you go over that number, risk goes up. And when you see a person who's on 100 milligram oral morphine equivalent, if they're a chronic opiate therapy patient that comes in a hospital for a surgical procedure, we need to know that their risk of overdose is tenfold. Non-fatal, fatal overdose is tenfold what an individual would be that was opiate naive. So addiction to opiates is not rare in chronic opiate therapy. The way this all started, and a lot of physicians in the room are of my era, and you went to the talks that were put on at the High Steakhouse, and you could order whatever you wanted and drink as much booze as you wanted, and it was all covered. We all went to those talks, and there was that guy who had that fancy presentation called PowerPoint that none of us could figure out how you use the damn thing, and it looked really good. And there was those messages that pain is common, that not treating it is unethical, that if you treat patients with pain with opiates, they won't get addicted to it, and that we have this new opiate, call it whatever you want, and it's especially beneficial in the treatment of pain because it has these pharmaceutical properties. So what we know now, though, is that addiction in chronic opiate therapy is common and can be up to 25% of patients. So we need to know that when we're seeing these patients we're cross-sectionally seeing these patients for an orthopedic procedure, or you're the anesthesiologist, or you're involved in this patient's care, and this patient is on chronic opiate therapy. Well, this patient has a 25% risk of having addiction. It's just like any other kind of risk factor. I see a patient who has diabetes and they got a hemoglobin A1C of 14. I know what their risk of developing cardiovascular disease is going to be over the next 1 to 5 years. Chronic opiate therapy, 6 months. So this is a person, well, call it 90 days. For our purposes, call it 90 days, okay? That's a real break point in the literature around chronic opiate therapy. So daily use of an opiate, 90 days. Risk is dose dependent, absolutely. Developing addiction, is it dose dependent? Yes. Yeah. The higher the dose you're on, the more likely you are to have dependence. Yeah, absolutely. So, and John will talk about this a little bit more, as we want to get you thinking about opioid risk tool, right? And we all have residents, and this is the kind of stuff we can get residents asking. All mood-altering substances act through a final common end pathway in the brain. And so if there is a history of alcohol, illicit drug use, or prescription drug use, misuse in the family, that puts that individual at risk. If my general risk of developing a substance use disorder addiction is about 13%. If my father was addicted, I got about 30%. If both my parents were addicted, it's 60%. So we need to think about that when I see an opiate naive patient coming in, they have a procedure, I'm writing a discharge prescription, this person's at risk, right? It's just like any other kind of risk stratification. Personal history of substance abuse. How many times in the last year have you had 5 or more alcoholic drinks on any one occasion? When you drink, how many drinks do you have? And in an average week, how many days a week do you drink? Just get an idea of how much they're drinking. Do you use other illicit substances besides marijuana? And I always tend to ask those questions as though the individual does use it. They can say, no, they don't use it, right? But I always ask it as though the individual uses illicit substances. And what other prescription medications do you use? Anybody between the age of 16 and 45. Don't even ask the person. History of pre-adolescent sexual abuse, more difficult to ask that question. And then psychological disorders are easy enough to screen for. And so you can do this opioid risk tool. It's relatively easy to do, and it gives you some clinical information about, is this individual at low, medium, or high risk to prescribe, and how much am I going to prescribe, and how am I going to prescribe on discharge? So John's going to talk a little bit about in the this is real risk from my perspective. An opiate can open. Rates of addiction are there are some opiates that are more euphorogenic than other opiates, and if you talk to people who have opiate addiction, they're going to tell you heroin's the best opiate going, and it always is. And that's in the addicted population. But if an individual is saying to me, I don't want to take an oxycodone because I'm going to get addicted to it, first question I'd ask is, can I use this stuff? Yes. And if it's no, then that's probably a lower risk patient, right? And then I get to be making decisions based on my clinical expertise. I'll talk to the patient that this is the opiate that tends to relieve the type of pain you're going to have the most efficiently, the most effectively. If you run into issues with it afterwards, we're going to get our service involved, manage that. But the key issue here is that there is that percent of the population that's going to have a problem. And identify who those people are, like doing any other kind of assessment, like a anesthetic assessment. We want to understand who are going to be the high-risk patients. That's who we're screening.
So we're talking about patients who are addicted, they have a substance use disorder, or they're high risk for a substance use disorder. So, who are these patients? The trauma service, off the cuff, anecdotally, will say that 50%, probably more, of their patients they see had intoxication, withdrawal, substance use in their path as part of their admission to hospital. So a large number. but they may be opiate naive. So they may have come back with a urine drug screen positive for cocaine, or there was some marijuana in their system, or they endorsed, binge drinking time to time. So with these patients, they're carrying a higher risk, as we saw from the opiate risk tool, of having a substance use disorder, of misusing opiates once prescribed. So how do we mitigate that risk in hospital? I think one thing that we notice is that patients who have one substance use disorder often are more at risk of opiate use disorder for sure, and their response to these medications sometimes is different. Whether it's that familiarity with the euphoria, no doubt they need it, but how do we mitigate it using immediate release at first rather than long acting to look at requirements. What does somebody need? Using a PRN schedule and monitoring closely for dose escalation. So we might go in and somebody say, I got high pain tolerance, I'm going to need a lot, but always kind of starting low and going slow. I think with our higher risk patients, we need to, from the get-go, have a plan that we're going to discontinuation, that it's not an open-ended question for prescribing, that there's a way of getting off it. And that's often what's encouraging to patients who are worried from the get-go that they're going to get addicted, so to speak, is, hey, this is the plan. I'm going to taper you most likely before going, but even after you're discharged. It's easy when patients are leading care to say, IV feels much better. Can we just keep doing that? In our higher risk patients, with that plan to say, look, no, we're going to, move over to opiates. That's a normal transition, and we're going to do that rather quickly. If there's a problem, let's relook at it more often. These patients often need more attention. Patients on chronic opiate therapy. So I'm seeing patients in the office these days who, probably in the 90s, early 2000s were put on opiates. Had a patient who was on 1,365 of oxycodone for a sore neck, imaging negative. Now, physician wanting to help them get off it. A little bit of a long road at 1,365 of oxy. And really, for that patient, not really a clear understanding of why this would need to happen, why we need to go down. But we have patients who, for one reason or another, ended up on high doses of opiates. Is their life really better? The literature is starting to show that, at doses above that 50 to 100 oral equivalents of morphine, the benefits go down, the risks go up. In hospital, we anticipate that they're going to need more. Their pain receptors are different. They're often requiring 1.5 times what they would other patients might need. So we're planning ahead again of what the trajectory of this person's stay is going to look like. I think sometimes we worry that giving them more opiates is going to get them more addicted or more dependent, something along these lines. These are patients who are already, physically dependent. They have tolerance. They would have withdrawal if we didn't provide opiates. So I think a recognition that if somebody's come in on it, they're going to have some opiate debt if we took them below that level that they came in on. Planning to return to pre-admission dosing prior to discharge, or as close as possible to discharge. Maximizing the things that they say, I've tried those and they don't work. Being aware of increased doses of opiates making the pain worse. This is a real phenomena. Patients escalate doses and find that they're getting more pain, need more, and it becomes a really negative cycle. Bringing down the dose actually improves pain management. These are the patients that we are happy to see as a service when the risk factors are identified early. So catching them early, referring, make some recommendations about about their course of opiates in hospital, and also preparing the patient because also often they're frightened, worried that somebody's going to take them off. And if you've known patients who've been on chronic opiate therapy, they've often gone through times where for not being prepared or a physician not willing to prescribe, they've run out early. And withdrawal, while not deadly, is very frightening for patients. These are the patients we would want a urine drug screen on initially. So they are higher risk for substance use disorders, and part of being able to detect it in somebody who's very invested in continuing on their opiates, using all the objective measures that we can have available to us. Yeah.
I mean, I know trauma does it automatically when they come in. If we're doing it as a service, do we need to tell the patient that we're going to be screening their drugs? Do you guys, or no, you don't, just ask them?
No, I mean,
Is it as an informed consent is what I'm
well, in circumstances where, like on the maternity ward, there's an obligation there. But if when I have a patient who's coming into hospital and I'm going to do complete blood count, liver function, etc., I don't require informed consent from that, and I don't know why I would require informed consent to do a screening tool that I need in order to make clinical decisions. So in trauma patients, like John said, 50% of trauma patients have a substance use disorder, and whatever percent of them ended up in hospital directly as a consequence of the substance use disorder, i.e., if they weren't misusing a substance, they wouldn't have come into hospital. In order to intervene on those people, we need that test to determine or give us an idea what substance we're going to be dealing with. Mm-hmm. So I strongly recommend just order it, and blood alcohol, and currently we still have to order fentanyl.
Yeah, I mean, it is an explanation for the patient as such. All of a sudden, day 2 or 3, going, oh, by the way, I need a urine sample. So that's what I'm just asking. Are you telling them we're actually, it's quite common, we're going to be screening you for opioids or other substances in your urine?
I would attach that urine drug screen to the medications that they're on rather than to the patient themselves. There's something we're seeing about the way you're dressed or the way you talk that we're suspicious of you. You're on a medication that requires, for safety reasons, to do this investigation. So it's attached to the medication rather than them. And if I really think a requirement of them continuing on that medication.
Yeah, it's framed in the as a medical investigation.
Okay.
Our methadone, Suboxone, buprenorphine patients are higher risk. Our eMERGE colleagues will tell us that when somebody comes in and there's a pain complaint, there's a belly pain, they're looking a little bit harder because these are the patients that have a higher mortality. They tend to have more problems with them. So one example of the patient who comes in for surgery. I have a patient recently, some of you might have been involved in the care, who had been on methadone for quite some time, had relapsed, transitioned to IV use, and on the way back from the safe injection site, crashed the vehicle into a tree, femur fracture. And, this is in the course of somebody who's doing something about their addiction. So somebody who's taken some steps to treat their opioid use disorder. Relapse is still a reality. They're by no means in the clear, so to speak. So I think high-risk patients, urine drug screen, one of the reasons why we want to see these patients is because things are not always as they appear. This is not the type of thing, I'm taking my ramipril or I'm not taking my ramipril. There's other motivations for telling their doctor that they are or aren't taking it. There's a reason why methadone, Suboxone are available on the street. The reason isn't because it's coming from somewhere else. It's coming from the patients that are prescribed it, who are selling it. A close check of Pharmanet involving the addiction medicine service for this, I think is a real necessity for these patients. They'll likely require higher dose opiates. The methadone, the Suboxone are for withdrawal management, so really a baseline, not for pain coverage. And this is a common misconception that because they're on methadone, they're going to have their pain, covered by that more so. And it's really not the case. It forms the background. In our really sick patients, like who are septic, maybe endocarditis, along these lines, the dose might need to be adjusted. So rather than just restart, we might be splitting the dose or reducing the dose because they're not tolerating it, or they require a medication that might interact. They are also at increased risk of other substance use. I think these are the patients that provide the interesting stories in hospital. The patients who, we had one who left hospital to go back to his family physician to get a prescription for oxycodone or hydromorphone or something like that, and then brought it back into hospital and had a big bag that was offering to other patients.
Yeah. I shouldn't laugh.
And these are the patients that we're wanting to work closely with for some of that behavior modification, engagement around their addiction, especially with the longer stays. I'll put this slide up because it's not uncommon to use different medications, whether it's sub-Q, IV, or oral. I think some options around this for our patients are using an oral liquid, so something that can't be put in the cheek and then spit out. Hydromorphone also comes as a liquid. And trying to stick with one form or one formulation of opiate in order to better calculate how much somebody's on. So if you're using hydromorphone, stick with hydromorphone rather than some oxycodone, a little bit of morphine here, a little bit of hydromorphone there. But really, that amount, that 50 milligram for chronic opiate therapy being kind of the ceiling where risk goes up after that, it's not that much. Routinely, we're all seeing doses much, much higher than this. And I think it was a bit shocking to my patient on 1365 when I told him that the goal wasn't to get him down to 1,000 or 800, it was to get him down to 30 or less. And I think this just sounded like, giving him like a drop in the bucket kind of thing, right? So, yeah, our addiction medicine service, core services that we provide, withdrawal management from whatever people are withdrawing from. Sometimes it's the weird and wonderful, but most often it's alcohol, it's opiates, benzodiazepines. We want to see patients who are on opiate agonist therapy. So this is Suboxone more and more, but methadone as well. Providing some diagnostic clarification regarding the existence of a substance use disorder. And sometimes it's just that, they have some risk factors. And, identifying it can change the trajectory for somebody instead of their hospital stay turning into something that enabled or propagated their addiction problem, something that maybe helped them turn the corner and do something a bit differently. So recommendations for pain and addiction issues, do we get involved on a day-to-day basis for every patient who's on chronic opiate therapy? No. Some, more appropriate to give some guidance, and, that's all that's needed. But there's certainly some who, because of their addiction issues, are much higher risk, and we're happy to be involved case-by-case basis. Behavior modification, and we all know who this is referring to, the patients who, right from the get-go, we're worried about being in and out of hospital. They're gone for hours at a time. They're missing doses of their IV antibiotics. They're not compliant with recommendations to be off their feet. One thing that's shown to be helpful is kind of short, small visits from our service to check in, make small changes. One thing that works is contingency management. So, if you behave in this way, there's this kind of way that we're going to act towards you, and kind of a back and forth. And then assessment and treatment for recommendations once people leave the hospital. So patients with addiction issues, maybe not for necessary acute management, for what they can do once they go. So when to refer, similar stuff, known history of substance use disorder, any methadone, Suboxone, any risk of withdrawal, risk or suspicion that they'll be escalating opiate requirements, and they're screening positive for substances. One thing I think that often happens is, the patient is asked, "Do you want to speak to somebody from addictions?" And I think that's fine. It's nice to talk to somebody who's interested in making a change. Do I think it's a requirement of a referral? not necessarily. And I think there's some value to saying, hey, look, we offered this patient something, and and I went to them and I said, here's who I am, here's what I do. We talk about this, and if they refuse, that's fine. I can document that, and maybe next time they'd be more open to it. So I think it's fine to respect patients' wishes. I think it's also fine to involve us, and we can make that call too. And refer proactively. We're available. I'll turn it over back to Paul for kind of the latter half of patients' visits.
So what we're trying to talk about is a lot about risk mitigation, and discharge issues really come into that. And so the key issues with discharge issues is we want to make sure that we provide adequate analgesia. We can't go ahead.
All of us work at Eagle Ridge Hospital as well as here.
Yeah.
Have you got any general advice about what amount of opioid use prior to their surgery would pretty much mandate that the patient should be done here at RCH because of addiction medicine being available, as compared to Eagle Ridge Hospital where there is no addiction medicine service?
Yeah, okay, so in answer to that question, it doesn't come down to a simple amount of opiates, but if I had to talk about an amount of opiates where risk is really going to go up and it's going to be more difficult to manage analgesia, it's going to be 100 oral morphine equivalents per day. But then you also got to look at the type of pain, right? So some types of pain are going to be much more difficult to control, and if you're doing a procedure on an individual that has let's say for instance if you're doing a procedure on an individual who has chronic non-cancer pain in the low back, and you're operating, or the procedure is on a different area of the body that isn't particularly prone to having a lot of pain, the chest wall, then 100 or more isn't going to be an issue. If you're operating on the area, the procedure's on the area where the pain is, then it's going to be more of an issue. And the key areas where we tend to see, this is a key point, where do you tend to see opiate-induced hyperalgesia? And you tend to see it where there's a lot of opiate receptors, right? So if you look at opiate withdrawal, you got low back pain, belly pain, head pain, and soft tissue pain. So if you have an individual on significant levels of opiates and there's going to be a procedure on those areas, then consideration needs to be given to RCH. And if you have anybody say on 1,000, and what it does, it tends to go like that, right? And where you need to consider that is in that range, right? 100 or 250 may be okay in individuals that the procedure is some other place in the body, but 100 may be a real problem in an individual who has neuropathic pain and is going to get operated on, and we're going to require things like ketamine and whatnot. Go ahead.
You mentioned the 50 and the 100 and showed a slide of equivalents. How do you equate the 50 and 100 equivalent of morphine to a maintenance dose of methadone with the same question?
Right. Yeah, really good question, because, as we all know, methadone is not convertible to other typical opiates. The research around it shows it's anywhere from 1 to 10 to 10 to 1. And when you convert people, there are protocols to do that if you're going from big dose typical opiates. Methadone is a different scenario. As we all know, patients on methadone, it's an NMDA receptor antagonist. They're not going to behave like people on typical opiates. So if you have a patient on 100 milligrams of methadone and 100 milligrams of morphine or oxycodone, they're not going to behave the same. The patients who are on typical opiates are going to escalate quicker. They're going to have pain hypersensitivity. They're going to perceive the pain quicker. They're going to require increasing doses. Patients on methadone, you replace their methadone dose. You give them 1.5 to 2 times the dose that would be required in a similar opiate naive individual with a similar medical procedure for 24 to 72 hours, somewhere in 48. Rapidly start to decrease the dose afterwards, and most of those patients will do okay.
So you maintain their methadone and use 1.5 to 2 times the analgesic narcotic.
Right, because they're pain tolerant. So treat acute pain aggressively in this population. They don't do well with acute pain. They feel pain more than people not on opiates. I mean, the research clearly shows us that. They're pain hypersensitized. They have pain altered pain perception. So treat the pain aggressively for a short term, get off the parenteral opiates as quick as possible, onto oral opiates, taper. Talk to them about what the treatment plan is going to be. We're going to treat your pain aggressively for a reasonable period of time, a short period of time afterwards, not so long we're going to get you opiate tolerant. We're going to have you off these opiates.
So you see no difference between a patient that comes in on 160 milligrams of methadone a day and somebody who's coming in on 350 milligrams of methadone a day?
No, those
You do
patients.
the same thing.
Well, you would do the same thing in those patients, yes. The patient on the 350 milligram dose of methadone is probably going to behave differently. If you require 350 milligrams of methadone, pharmacologically, you're a different person.
Okay.
And if we don't know that patient from anybody else, they're coming to the hospital the first time, I see somebody on a high dose methadone, I'll treat them differently in the sense, are they using all of that, right? So is that all getting into them?
But
So like Doug asked then, at Eagle Ridge, where we don't have you guys and we don't really have anybody who can handle the methadone easily, what cutoff do I use in the pre-admission clinic? Saying, you're coming in on 160 for a procedure that's not terribly painful, I'll do you. You're coming in on 160, you're having a back surgery, for disc, I think you should be done at the Columbia. Where do I make that decision?
Yeah, that's a difficult question to answer. If I had to throw a number out, I would throw the number 200 out.
Okay.
And the reason for that is because with synthetic fentanyls, when my patients relapse to synthetic fentanyls, they end up on 200, 250 milligrams of methadone to get them to stop using fentanyl, and then I'm trying to taper them back. The Suboxone and fentanyl just isn't working like it used to work. Go ahead.
How do we manage preoperatively, intraoperatively Suboxone, especially at places like Eagle Ridge?
Please get our service involved. This is a really tricky area.
At Eagle Ridge, we don't have your service.
Yeah. So here's the issue on it. There's two issues on it. An exemption currently is required to write Suboxone. There are protocols for management of Suboxone. Michigan University in Michigan put out a pretty good protocol about 3-4 years ago. I strongly disagree with discontinuing that medication prior to the surgical procedure, because then the individual goes out on opiates and they're going to have a relapse. And this is what this talk is about. We're trying to avoid those non-fatal and fatal overdoses. And so what has to happen is we need to back those people off to 2 to 4 milligrams, preferably 4. And at 4, you still got around 30% of the opiate receptors occupied, and I mean occupied. The binding capacity of Suboxone at the buprenorphine component at the opiate receptor is much higher than pretty much any other opiate. And then you have to use an opiate with really good binding capacity and affinity, such as hydromorphone, in order to manage their pain. And it needs to be used at significantly higher doses. And then Suboxone needs to be titrated back up. And as you're titrating up the Suboxone, it's occupying the opiate receptors in a geometric curve, right? So as you go up in the dose, 16 milligrams occupies about 65%, but 8 milligrams occupies 65%. 16 milligrams occupies 92%. So when you're on 16 milligrams of Suboxone, managing analgesia is really difficult. So you don't want to get up there too quick.
And we've done that quite successfully with a number of patients, having you involved, where you drop it down to 4, and then we reverse the cycle as they get through.
So there's no in Suboxone. There, we talk about protocols. The Americans are great on protocols. It's a case-by-case basis. They have to be individually managed on a day-to-day basis. The general rules are and you'll see the elective cases at Eagle Ridge. There needs to be communication. You want that patient down to X dose prior to coming in, preferably for a couple of days. The community physician, you may have to communicate with them. They may need to put on some typical opiates prior to coming in, and on 4 milligrams. If they're on 4 milligrams for, say, 48 hours beforehand, you've got good dissociation and you'll be able to analgesize them. But the majority of patients we're seeing trauma patients.
So 2 quick things. One, it sounds like Suboxone patients would be far better served here, but we do see still, as Doug and Paul mentioned, the methadone patients come into Eagle Ridge, and if they're just a day surgery, usually it's not so much of an issue because they can have had their morning dose, they're going to go home that day. But we do have patients that are admitted for a day, 2 days, a week kind of idea. And with no one from addictions out there, of course, the vast majority of us don't have methadone prescribing. Now, I know that you can actually fill out a form to temporarily allow you to do that, but then you brought up the whole issue of, well, figuring out are they actually on their full dose and not. So are there any recommendations on sort of how to approach that issue where we're not regular methadone prescribers and, so we don't deal with these patients on a regular basis and be able to tell whether they're taking their full dose?
Well, I'll answer that, and we're in the middle of an opiate prescribing epidemic. It's not going away soon. You're going to see a whack of these patients. My recommendation is get a hospitalist exemption for methadone. It's just a piece of doing hospital-based practice these days.
And if they're elective and you have time to prepare, you got the chance to communicate with their provider. So if they're on methadone Suboxone, they got somebody who's following them, and they might say, this is an unstable patient. This is somebody who, I've had problems for whatever reason, or I've known them for 2 years. They've been very compliant, and you might get a totally different picture. And then in one of those patients, you might have more comfort being the prescriber for them for methadone, and a little less worried about them using other substances and overdose.
And in that group, often we'll see you split the methadone. If there's any, question whatsoever, I think that's what you're asking. You're asking the actual management is typically you'll split it to three of their 3 doses.
Yeah, it's urine drug test. You look at the Pharmanet. If they're on daily witness ingestion, you can pretty much say that yes, they're getting their methadone on a daily basis. Pharmanet data is inputted in the morning and not taken out until night if the patient doesn't go to the pharmacy. So, you see the patient at 2 p.m., well, you got your dose this morning. No, the pharmacist just inputted the data and will take it out at night if they don't turn up. Urine drug test will tell you what they're using. And we look at methadone, not the metabolite. So if they're on very low dose methadone, it'll disappear quicker than the metabolite will disappear. If they're only on 12 or 16 milligrams and they missed 48 hours, you may not see it in the urine drug test. Splitting the dose in anybody over 50, 100 milligrams makes sense because, at least in our hospital, they come in for trauma. The trauma occurred in the setting of a methamphetamine or cocaine relapse, and now they're going to crash and they're sedated, or there's other benzos or intoxicants on board. So you don't give them the whole 160, you give them 44 times a day, and in case it's too much, then you can back it off with the next dose. General rules like that, but the college puts on a really good course for individuals that prescribe methadone in hospital, single-day course.
Sorry, just to go back to the Suboxone, because we're starting to see more and more patients coming into the pre-admission clinic on Suboxone. Is there, again, a certain cutoff where they're on a level of Suboxone where we should do them at RCH? I'm just thinking about, trying to cut them back or titrate them. I mean, we have some outlines and protocols for bridging therapy for low molecular weight heparin and things like that. Is it possible to come up with one for a Suboxone wean in the preoperative period to help us manage this?
Like I said, University of Michigan came up with a protocol for elective patients being electively admitted on Suboxone. Works pretty good if you can get those elective patients. And what they recommend is reduction in dose. And so the dissociation of Suboxone takes at least 48 to 72 hours from the receptor. The key dose is 4 milligrams. You can analgese people if they're on 4 milligrams. 8's more difficult. 16 is really difficult to analgese patients. You need PCA with significant background and pump to analgese patients to knock it off the receptor. But 4 milligrams, those patients are analgesable for the majority of procedures. So what I would be doing is if you see those kind of patients, you would be communicating with the community physician and saying, here's our protocol, the Michigan protocol. What I want you to do is I want you to reduce this patient's dose to 4 milligrams, and they should be given a typical opiate on a daily basis for 3 days beforehand, morphine, in a form in which it can't be, the route can't be altered easily. Morphine, oral syrup, so it can't be injected is what I'm saying. And then you get that patient, the urine drug screen should show the opiate that they're getting, should show buprenorphine, which we don't test for in hospital, but certainly can be tested for. And those individuals are not going to be too difficult to analgesize. And depending on how long they're in hospital, if they're in hospital for 2 days, then they can go out on 8 milligrams with a short tapering prescription of a typical opiate. The methadone.
We don't go to the pre-admission clinic. We don't see these patients again.
Oh, no.
In regards to prescribing the
You should not be doing the. You should not be telling the patient, "I want you to reduce your dose to 4 milligrams." That should be the Suboxone prescriber's responsibility. And that's going to be probably a different talk.
I know, and I'm just logistically thinking, because we're often phoning the family doctors, their offices, but like, we're in pre-admission clinic for maybe 8 hours, and then we're not back there for weeks on end, and then the patient just sort of gets lost.
Yeah, and we're certainly more than willing to work with you on this as far as setting up a protocol that, goes to the Suboxone prescriber clinic fax. Here's what I'm advising you to do.
Maybe help with that.
Yeah.
Go ahead.
So a little different from my perspective. I mean, these complex molecules, I trust you guys to manage. What I would like to hear is how we can help prevent the epidemic. And I'm mainly talking about discharging.
Let's talk
10
about that
years
now.
ago when I came out, I left. We discharged patients total knees on Tylenol 3.
Yeah.
And now, if I don't give oxycodone prescription for ACLs, I get 5 calls from the recovery room. And the other question I have is then how much? I'll be honest, my naivety, I just pick a number, 60, 80, some days it's 90, based on the look and probably value judgments on what the patient looks like. Is there any guidelines?
Yes. Okay. Let's get into that right now. That's the piece I want to talk about. And one thing I want to preempt this little bit of a talk on is I read a recent report out of the United States that showed that of individuals prescribed opiates post-operatively, 25% of them were still taking those opiates at 90 days. Okay, so that's what tends to happen. And the question is, how can we prevent that? So we got to provide adequate analgesia. We got to minimize the risk to the patient. I got to minimize the risk of diversion. So public safety. Here's my recommendation: 5 to 10 day tapering prescription. Okay, it's a tapering prescription. Is it 5 or 10 days? I tend to use the rule if it's 50 milligram oral morphine equivalents, it's a 5-day prescription. And you look at that individual and they're not taking opiates prior to admission. They're not dependent on opiates. They're not going to be dependent or develop a withdrawal syndrome on discharge. It's a tapering prescription. I start at the dose at which they took yesterday. And I dispense daily or day 1 and 3 if it's a 7 or 5 day prescription, and additionally day 5 or 6 if it's a 10-day prescription. I use the rule, if this patient took the entire amount of these opiates in one dose, what would happen? And normally, an individual can take double the daily dose and it'll be a non-fatal overdose.
That can be.
Not what?
I said, with these people that have problems with ambulation and mobility,
yes,
going back and forth to the pharmacy 3 or 4 times for a prescription isn't really possible.
So pharmacies will deliver.
Okay.
And that can be indicated just on the triplicate pad, delivery, okay. And the patient's responsibility to find which pharmacy will do that, but a lot of them will. If for a while there, the methadone scripts didn't have a kind of a tick box for this, and pharmacies were using it as an incentive to get more methadone patients coming to their pharmacy in particular. So there was a busload coming from Coquitlam to the downtown east side, picking everybody up or delivering around to East Suite. Sometimes they were just bringing them right back to the pharmacy and then witnessing them there. That was shut down with the new prescription pad, the pink one for methadone, saying its doctor has to sign off on delivery being okay.
So West Coast Pharmacy, Edmonds Pharmacy, they routinely make a business out of delivery. But a key issue here is that that medication needs to be dispensed not all at once, because then the individual can potentially experience a fatal or non-fatal overdose and can take the medication too much, continue escalating when they're out of hospital. Avoid additional sedatives, benzos and zopiclone. If we look at fatal and non-fatal overdoses, something like 50% of those overdoses, fatal overdoses, also have benzodiazepine. So we got to avoid prescribing those drugs for safety. Review Pharmanet. Pharmanet's going to tell me how much and what else is at home. So if I'm prescribing a whole bunch of medications on discharge and the individual already has these medications at home, I'm providing additional medication. I may not need to prescribe anything. If the individual picked up 700 milligrams of oxycodone the day prior to admission, I'm going to assume they have it.
Is it a reasonable thing if somebody says they've got hydromorphone at home, which they've been taking in the past, to just say, well, we're not giving you anything and take what you've got? Because a lot of patients do have it from previous surgeries, from whatever.
And document on the chart about how much do you have and give them some explanation how to take it and how much to take it. Yeah, absolutely. Common sense. Why give the individual more opiates? And I'm always thinking about risk mitigation. Because, I do a lot of medical legal work, and I'm always looking at the worst possible outcome. Is this defendable? Why would I give an individual more opiates when I accessed the Pharmanet and saw that that individual already had substantial opiates? Maximize the non-opiate modalities, NSAIDs, etc. else. And here's where we consider the opiate risk tool. If I don't know exactly what this individual, I don't know how much of a risk this individual is, I can eyeball them, but not, tattoos are not necessarily, they don't have that kind of positive predictive value they used to. So I do that opiate risk tool, and I ask questions about former substance use, family history of substance use, treatment, etc. Consult our service, talk to us. We're more than willing to do that. And communicate with the community prescriber. You do the surgical procedure, you prescribe enough opiates to manage that condition, and you're not the chronic opiate prescriber for the condition. Patients on methadone and Suboxone, we are more than happy to facilitate discharge medications in our hospital for this. We're more than happy to take telephone calls and talk to you about it. This is a higher risk population. They have tolerance, they have altered pain perception. They're the individuals that have a history of misusing opiates, altering the route of administration, overdosing. These are the key individuals to maximize the adjuvants on. When you're going to write discharge prescription, it needs to mirror the methadone. So if there's going to be consideration of giving this individual a carry on their methadone when they were daily witnessed ingestion prior to admission, there needs to be some communication with the methadone prescriber about that. So, and documented on the chart. So there's some risk mitigation, like, yes, this individual can't get to the pharmacy. We've looked at delivery. That's not available. We're going to balance the risk. We're not giving him a week. He's simply going to have to go on day 3. Like I say, communicate with the methadone prescriber, and at a minimum, fax your prescription to his office. The methadone prescriber is probably only there a half day a week. These guys are hard to get a hold of commonly. I'm only in my clinic a half day a week. They have my cell phone number. Doctor calls, they give them the cell phone number or call me and I call them back. But from a risk mitigation standpoint, fax the prescription to the methadone clinic so that the methadone prescriber knows, okay, my patient got this. Clinic and follow-up. So when you see the patient in the clinic, after they've had the procedure, Pharmanet review is now mandatory. You got to look at the Pharmanet to see what else is on it. These are high-risk patients, and there needs to be a single prescriber. So this is not only do you look at Pharmanet to see what else is there, you look at Pharmanet to define your role, because it may not be your role to provide an ongoing prescription.
So when you say a single prescriber, is it fair to actually put that on the family physician or whoever has been their previous prescriber? Because isn't that where problems sometimes arise when multiple people start getting involved, and the hospital is an opportunity for that?
Okay, so we did a surgical procedure on the patient. A surgical procedure was done. That surgical procedure normally requires 7 to 10 days of a prescription.
Right.
I'm the surgeon. I wrote that prescription. That is adequate analgesia. I looked at that patient. I've determined that there's no complication. There's not a hematoma, neurovascularly defined. It's my opinion that adequate analgesia in the form of opiates has been provided. NSAIDs and Tylenol are what is required here, I'm not prescribing.
So what I guess I'm getting at is rather than giving 7 to 10 days, does it make sense for you to give just a very short period of time and tell them that their analgesia needs to be carried on with whoever's dealt with it in the past?
Well, if they're on chronic opiate therapy, I think that's a really good approach. But my approach from a balance standpoint is, what would a normal person require? How many days worth of an opiate analgesic would a normal person require for this procedure? And I'm going to give them that.
On the patient side as well, most patients, you can't get in your family GP in 3 days, right? So again,
If it's an elective procedde, you can plan it.
yeah, potentially.
So when I'm talking about single prescriber, I looked at the Pharmanet and I gave this guy 7 to 10 days worth of an opiate. They're back at the clinic seeing me in follow-up, and then I see there's a couple of more prescriptions in there. That's a risky scenario, and I'm not going to prescribe anymore. Risk-benefit analysis says I prescribed, there's a fatal, non-fatal overdose or some other negative outcome. Why did I give that individual the prescription? They're already getting prescriptions from other individuals. So it's about not enabling, and this is how we prevent chronic use of opiates occurring. We don't prescribe in inappropriate circumstances. Ensure that there's no other sedating medications. Recognize that other sedating medications are a huge risk factor, and consider an office-based urine drug test for high-risk population. Okay, I'm going to go over this really quick. These devices are extremely useful. There's high sensitivity, high specificity. I'm talking 98% on either side. You can get 11 or 12 substances to test for, and the individual comes back to the clinic. It's apparent they still have pain. I do an opiate risk tool. They look okay. There's a bunch of tattoos. I don't know. I get a urine drug test because it's the standard of care. I'm telling you, it is the standard of care to get a urine drug test when you're prescribing an opiate for an individual who you are not the regular prescriber for. Okay? That's the standard of care. So you say, fair enough, I need to get a urine drug test. Why my doctor wouldn't do that? Fair enough, you can see your physician then, but it's the standard of care that we get this test. And bottle, dip, and 3 things are going to turn up. So what happens is you prescribed morphine for the individual, and that's all that's in the urine drug test. I've mitigated a risk. This individual still has pain. I can say something to the extent that, fair enough, my opinion is that you're going to have pain for another 3 days or 4 days. I'm going to give you enough opiates to cover you for that, and then we're going to stop. What should be there isn't there. I prescribed opiates, and there's no opiates. And the last prescription was picked up on day 7. We're now day 9, or it should be there. I'm not going to prescribe. The individual is indicating that they're taking the opiates, they're not working, but they're not in the urine drug test. That's a problem. And I don't know what the answer to that maybe is, but I know what's not the right thing to do, so I'm not going to prescribe in that circumstance. I think it's really difficult to be criticized for doing that. If you got a urine drug test that's negative for a medication that's supposed to be there, and the individual is asking for it, it's hard to criticize you for not prescribing. And I'm certainly willing to, provide an opinion that that's the appropriate thing to do. And then the most difficult one to deal with is what shouldn't be there is there. So you prescribe morphine, and morphine is there, but so is oxycodone, and so is some cocaine, and maybe a alcohol metabolite. What are those kind of circumstances? What do you do in that circumstance? And that's where you need to have a discussion with the patient about what's going on, and maybe a telephone call to our service, because those are the really high-risk patients that a decision tree needs to be gone through about, does this individual actually have pain? Are you treating withdrawal? Are they active in their addiction? 60% of the patients I see in my methadone clinic started on opiates because of pain. You get patients in good recovery, they have a surgical procedure, they have pain, they get opiates, they're active in their addiction pretty quick. So those are the difficult ones, but strong recommendation. These things are $10. You may not be able to bill for them. They can really save you in certain circumstances, and I can tell you how to get a hold of them. Yeah, and then we'll wrap her up. That's how you get a hold of Pharmanet. You go to medi.net, and sign up. Costs you $100 a year. You can get it through Fraser Health too, apparently. What kind of aberrant behaviors are probably more predictive of addiction? Forging prescriptions is number one.
Chewing them to make them work faster. Kind of thing.
90 days is the key cut point. And John was going to talk a little bit about the new CDC guidelines.
So just one thing to peruse sometime in the next week is the Center for Disease Control in the States just came out with new opiate prescribing guidelines. And, good resource, highlights from it. It talks about risk factors, what to look for, using a pharmanet. They say that specifically not all jurisdictions have it, we do, so there's not really an excuse for not using it. Urine drug test, avoid other sedating meds, arrange treatment if you identify or suspect that an opiate use disorder is present. So just to summarize, give us a call, use pharmanet, sign up for it if you don't have it, mitigate risks when prescribing by doing some of the tricks we were telling you about, not dispensing more than needed, frequent dispensing, short prescriptions, screen for addictions. Thanks.
Thank you, guys.